Venice Omona,
Okay.
you're most welcome. You're most welcome for
Surely, thank you.
a series of CPD for Uganda Medical Association, Acholi Branch. Now, officially, I would like to welcome you to start the presentation on essential newborn care. You're most welcome, Dr.
Thank you.
Dr. Mona Venice is a pediatrician in St. Mary's Hospital, Acholi. You're most welcome, sir.
Thank you very much, Jimmy. Thank you. Thank you. Yeah, like I was saying earlier, we're going to really talk about essential newborn care or immediate care of the newborn. And the reason why this is an important topic is that babies are being born literally every now and then. And then a number of us who are attending this meeting, either healthcare practitioners who are handling these babies, or some of us are parents, and the others are potential parents. Now, as a country, we also lose a number of babies because of gaps here and there. So this presentation is not going to be very academic, but rather the realities of things. So I welcome you all to the presentation.
Thank you. Go ahead.
Yes. So really in the background of this is Uganda as a country, we lose a lot of newborns. We have made strides from Ministry of Health and UNICEF statistics. We have made strides in reducing infant and under 5 mortality from 158 per 1,000 live births in 2001 to 46.4 by 2018. But unfortunately, the neonatal mortality has really stagnated for several years at 27 deaths per 1,000 live births. Now, this is the national statistics. So we have areas in the country where the figures are a lot higher than this national figure. And unfortunately, this part of the country is one of those areas that has an extremely high neonatal mortality rate. Yes. Yeah, so neonatal period is basically 28 days of life. And the medical people know this. And we know that the majority of our babies, the neonates that we lose within the first week of life, okay? So there are a number of them that we lose on day 1, and then between day 1 and day 7. And a combination of those accounts for over 75% of the neonatal deaths. And this means that, you know, there are a number of things that we are probably not doing right before the delivery or at that point of delivery, and then immediately after the baby is born. And this presentation is supposed to help us, like, you know, highlight some of the things that we need to do. I believe that we have been doing some of these things, but the healthcare practice is a lot of apprenticeship. And sometimes, like, you know, there are certain practices which are deemed obsolete, which we are still doing. And this might be contributing to, like, you know, this high mortality that we are seeing. Yes. So what does, you know, like all these neonatal deaths, what do they actually, like, you know, reflect? Okay. When we lose a baby during the neonatal period, most likely the problem is we do not have, like, you know, good quality newborn care during labor, childbirth, and the immediate postnatal care. And this is very closely related to the, you know, the 3 delays, you know, that we have often talked about in healthcare, okay? Delay in decision to seek care, delay to reach facilities, and delay to receive appropriate obstetric and neonatal care at health facilities. Now, this sometimes is, you know, out of sheer negligence, but then again, also some of this could be because of some knowledge gap, okay? And this is the reason why we want to, like, you know, pay attention to what a newborn, every newborn needs, irrespective of where they have, you know, been delivered. And this takes us to the concept of the immediate or the essential newborn care, okay? We know very well that the majority of the babies, okay, are born healthy and at term. If you are to look at, it's like an inverted pyramid of sorts, okay? The bulk of the babies who are born are actually normal, okay? And they require just the routine care. But then also, if you don't give them this routine care, okay, a lot of them are not going to survive over time, okay? So the essential newborn care, the immediate newborn care is really a set of a package of things that we need to do to improve the survival and well-being of of the newborn babies, okay? So this takes care of activities right at birth, and then care subsequently up to about the 28 days, which is the neonatal period. Yes. Now, what do newborns need, irrespective of where they are born? There are basically 4 things that every newborn would need, okay? 1, they need to breathe normally, okay? 2, they need to be protected. And the protection is not from being bitten or anything, but rather from infections, mostly, okay? Therefore, it means that we need to be very hygienic when we are handling these babies, okay? The 3rd thing that they need is warmth. Every baby who is born has not yet developed, fully developed temperature regulation mechanism that you and I have, okay? So a lot of times they need to be supported, okay, by providing them the kind of warmth, the optimal warmth that they will need. And then finally, they need to be fed. And by being fed, we are focusing on the mother's breast milk, okay? So the baby needs to be breastfed. So most babies, irrespective of where they are born, whether they're born at home, by the roadside, in a hospital, in a health center, they need those 4 basic needs for them to survive, okay? And most of the talk is going to focus on these 4 basic needs, okay? Yes. So what are some of those interventions that are packaged in this essential newborn care? There are about 10 things, but we're not going to talk about all of them. We're going to talk about the most important ones, which fortunately also are the most basic. A lot of them do not require a lot of resources for us to implement, okay? All we need is uniformity in practice. Everyone should know that these are the things that need to be implemented at all times, okay? And 1 is a clean childbirth and cord care. This is basically to prevent the newborn infections. And we have talked about one of the things they need is protection. They don't need a gun. They need you to be sanitary when you're dealing with them, okay? So things like, the universal precautions come in handy in this. Then initiation of breathing and resuscitation. One of the things they need, we said, is they need to breathe normally. If we are not afforded that opportunity, we wouldn't be having this meeting right now, okay? So we are fortunate to be where we are because probably we're, given this privilege at the time we were born, okay? Now, you need to identify those ones who are not going to be able to start breathing by themselves and help them to start breathing, okay? And if you do that very well, we are going to limit, okay, the number of babies who most supposedly will have the diagnosis of birth asphyxia, which we also know that is one of the biggest contributors of neonatal mortality in our settings. The other one is thermal protection. You need to prevent and manage the newborn hypo or hyperthermia. Because these babies have not yet really developed their temperature regulatory mechanisms, they are prone to getting to the extremes of the temperatures, okay? If you leave them exposed, they're likely to become hypo. They're likely to become cold. If you overcover them, they are likely to become too hot. Unfortunately, they don't have that mouth to tell you that, I am dying because I'm too cold or because I'm too hot, okay? So as a health practitioner, you're supposed to know that, these are the measures that we have to put in place so that we avoid hypothermia. And these are the measures that we have to put in place to avoid hyperthermia. For the people who are working in the hospitals, we tend to see a lot of supposed neonatal sepsis. Most of these babies come in because they are hot, but very few of us try to dig deeper and find out what has actually been happening after birth, okay? Rain is back, so the temperature is a little bearable. But we all know how it has been in these last few weeks and months. Very, very hot. So in this very, very hot climate, the babies are being covered and it's only the face that is left. And no wonder they'll come with these very high temperatures. And if you are a healthcare practitioner who is not curious enough to ask the difficult questions, you're going to start treating this baby for sepsis when the baby is hot because they have been overcovered, or the baby is hot because the baby is dehydrated. Okay. And then early and exclusive breastfeeding. The recommendation globally is that breastfeeding should be started within the first hour of childbirth. And this is supposed to apply for both babies delivered, normally and those delivered by cesarean delivery. Unfortunately, for those who are delivered by cesarean delivery, a lot of times these babies are separated from their mothers. Yes, it's understandable that sometimes, the babies are not very well, or the mother may not be very well, and the condition of either may not afford them to start this. But considering the fact that the majority of the babies are delivered normally without major issues, you're supposed to ensure that your breastfeeding is started within the first hour of childbirth. So how do we ensure that we have good outcome for our newborn babies? I think there are basically two things. One, you need to anticipate. If you anticipate that this delivery is going to be a difficult one, you're going to subsequently make adequate preparation for this childbirth. One of the unfortunate things is that most of the time, even when we know that, for example, a baby may require resuscitation, we are not prepared, okay? So we take things for granted, and the baby comes out, the baby is not breathing. That's when we start running around looking for the resuscitation equipment. And in that process, usually we are losing time which will translate into a loss of life. And that is very unfortunate. Yeah. So what are the universal precautions? We said the babies need protection, and really they need protection mostly from infections. You've got to wash your hands. Gloves. We can't emphasize that enough. Hand washing always goes hand in hand with use of gloves. Okay, the use of gloves does not mean that you can forego washing your hands. The other thing is that you have got to protect yourself, because if you're not there, who is going to take care of this baby anyways? Okay, so we need a healthy healthcare practitioner. Okay, so you've got to protect yourself. Waste disposals, especially the sharps and the infectious wastes. We should all by now know where to put the different kinds of waste. Okay, dealing with contaminated laundry and sterilizing and cleaning contaminated equipment. Yes, we appreciate that sometimes during birth, equipment are used, okay? But after you have used, what are you supposed to do with them, okay? So the universal precautions really very, very, very important in the survival of our newborn. Yes. Preparation for birth. We talked about anticipation, okay? Hand washing, and then there are those essential areas that, all of us must think about. One, you need a drought-free or warm room, temperature of about 25 degrees Celsius. It means your labor suit shouldn't be this place that is open, no windows, shutters, and all these things. No. Okay. Two, you need a clean and dry and warm delivery surface. Don't put your baby after delivering on a metallic pan without any sheet. Okay. Where possible, you need a radiant heater or a radiant warmer. Okay. Bare minimum, you need two pairs of, you need a pair of towels. Okay. One you're going to use for drying the baby, the other one you're going to use to cover the baby. You cannot use the same one you've used for drying the baby to cover the baby, because by the time you finish drying, that towel is wet. And if you use that to cover the baby, you're predisposing this baby to hypothermia. Okay. You need some pieces of cloth. You need a suction device. Now, suctioning in the past was done for every baby. The current recommendation is, if this baby is born and is active and is crying and all these things, you don't need to suction. But if you have a baby who is born, for example, through meconium stained amniotic fluid, or the baby is very floppy, is not breathing well, then you may suction if there are secretions in the mouth and the nose, okay? And the rule of thumb is the mouth first and then the nose, okay? Because the moment like you do that, that process of suctioning is actually stimulating, okay? So if there are secretions, including meconium in the mouth, this baby is going to take the first breath and is going to aspirate, okay? Resuscitation table. We can't emphasize this enough. Yes, the majority of the babies don't require any resuscitation beyond the routine care. But as part of anticipating anything that can go wrong, you have got to have this in place, and it should always be prepared. Now, in a high volume facility, for example, you may need more than one resuscitation table, okay? Because you're going to have like several mothers delivering at the same time. You don't want to be caught off guard by 2 or 3 requiring like a resuscitation and you have a single resuscitation table, okay? You need ambu bags and masks. This is another problem, okay? When you have not anticipated, you have not prepared yourself, you're going to have the baby out, the baby is not breathing, the baby is not crying, and then there's no ambu bag, and you're going to start running around. There is the very important concept of the golden, the golden minute. You're going to lose that. If you have to run from the labor suite to your theater to look for an ambu bag, you can imagine, okay, the fate of the baby. Where possible, oxygen. A number of our facilities have wall oxygen. Where you don't, there are oxygen concentrators. Then like the disposables, there are medications. Medications for the babies, the most important one is vitamin K. But then sometimes they require other medications beyond that, including nevirapine, okay? So you need to have these things, there. And then you need a clock. One of the things that we are going to see is every baby who is born, you have got to call the time of delivery, the time of birth. It is very, very important, okay? So every delivery room should have at least a functional clock, yes. So the immediate care, you need to provide the routine care for the newborns, and then also you need to identify and manage newborns who have special needs. Now, today we are talking about the general aspect of the care of the newborn. Maybe in another series we shall have a presentation on the care for the sick newborn. When I was approached to present this, the intention was to talk about the care of the sick newborn, but I thought we needed to start from what some of you would call the first principles. What are the things that we first need to do for all of them, irrespective of whether they are sick or they are not? What are those key things that we must do for them? So in another presentation, we shall probably the organizers will have someone present on the care for the sick newborn. Yes. So for the routine care, one, like I emphasized earlier, you need to call out the time of birth and the sex of the baby, okay? You've had scenarios where the parent wants a baby boy, but it's a baby girl. And because during that time you did not call out the sex of the baby, they can go ahead and say they swapped my baby. So to avoid that confusion, you need to call out the time of the baby, okay? This is important, okay? The other thing about the time of delivery is that it helps to alert the other team members on whether this baby may need some kind of help, okay? For example, if we know that the baby has come out at 3:30, and this baby probably is not breathing or has not cried, and the baby needs, to be helped to initiate breathing. You know that my golden minute is at, the peak of it is at 3:31. I have this 1 minute, okay? The other one is placing the baby on the mother's abdomen. Now, I think for a long time, the practice has been, once the baby comes out, cut the cord, go and separate, like you'll put the baby like, in a cot somewhere or on a counter somewhere. The recommendation is the baby is out and the baby is breathing, the baby is crying, the baby is kicking around, put that baby on the mother's abdomen, okay? The mother is the best source of warmth for the baby. Don't cut the cord and take and put this baby under a radiant warmer. No, the mother is there. And we have said the mother is the most cost-effective ways of providing, warmth for this baby, okay? The other thing is that you need to dry the baby with a warm, clean sheet. Remember earlier I said you need at least 2. One you're going to use for drying the baby. After drying the baby, definitely that one is going to get wet. So you need another dry one. So you're going to put this baby on the mother's abdomen, the mother's tummy, and you're going to cover the baby together with the mother as you go about doing the other things, okay? Then you need to wipe the mouth and the nose with clean cloth, preferably sterile gauze, okay? You need to assess the baby's breathing. As you're drying this baby, you're stimulating the baby, okay? And any baby who is born without issues, that process of drying is enough to stimulate them to start kicking and crying and all these things, okay? But there are those who are going to as you're doing that, yes, they're going to start breathing, but you'll notice that the breathing is not what is considered normal. So as you're doing the drying and all that, you're assessing is this baby breathing how, a newborn baby is supposed to breathe, or something is not right. And if something is not right, probably this is not a baby you're going to put in the mother's, abdomen and leave there. This baby might have to be taken away, okay? So that some other levels of, care are instituted, okay? Then you need to clamp the cord after 1 to 3 minutes. Delayed cord clamping. After the presentation, I'm sure we shall have discussions. My colleagues in obstetrics will tell us if this is something that, they are practicing, okay? I know the American College of Obstetricians and Gynecologists recommend 30 to 60 seconds, but the WHO is 1 to 3 minutes, okay? And this is irrespective of the mother's HIV status. In a number of settings where HIV is prevalent, like ours, there have always been these questions of if the mother is HIV positive, are we also supposed to implement the delayed cord clamping? The recommendation is yes, okay? The only thing that is discouraged is milking the cord, okay? Evidence has shown that even for the mothers who are HIV positive, delayed cord clamping doesn't increase the risk of this child getting infected with HIV, okay? Then you need to use sterile equipment for cutting the cord as well as for tying. Put an identity label on this baby. Some of us who have been in practice, we have had stories of parents claiming, my child, was swapped, or they gave me a dead child, or someone took away my son and they gave me, a girl and all that. So you need to identify, and this you can put on the wrist or you can put on the ankle, okay? So you need to identify, this is the daughter and so, and clearly that label should be there to avoid confusion, okay? Examine these babies for malformations and birth injuries. A number of times in pediatric practice, we get babies with congenital malformations, and they're coming to you way, way, way beyond the neonatal period. And when you go back to the birth history, they'll tell you the baby was delivered and they were discharged the following day. The question is, whoever discharged them, did that person actually know that this baby had issues? and they just let it go, or like, they didn't examine these babies at all. Birth injuries. We receive a lot of babies with, for example, fractured clavicle. And these are things that, you're supposed to be able to even if there is nothing that there's nothing that you're going to do immediately, because we know for some of them, things like, fractured clavicle, they heal without any intervention most of the time. But did you identify that actually this baby had this problem? Okay. Or you are trying to be economical with the truth, and you're like, you know what, I don't want the parents to ask me too many questions, so I'm not going to disclose to them. So it's very important that you examine these babies for these malformations. You have babies with anorectal malformations, imperforate anuses. Okay. If you don't examine this baby, you are not going to know. You're going to discharge, the mother is going to come back and the baby is not doing very good. So we need to be able to identify, okay, these malformations and injuries. Let the caretakers know. If there are things that can be done about them, they should also be able to know. If there are things that there is nothing that can be done in the immediate term, you also give them that information such that when they go back home, they at least know what is going on. They're not in the dark. Initiation of breastfeeding within the first hour, very important. This one cannot be emphasized enough. Okay. Unfortunately, like I mentioned earlier, for the babies who are delivered by cesarean deliveries, a lot of times they're separated from their mothers. And we tend to lose this first hour of what? Breastfeeding. Yes, if the baby is okay, I'm sure you can keep the baby with the mother when the mother is still in recovery. Okay. The colostrum is very important for this baby. You don't want them to miss on that. Okay. And that's why there is a lot of emphasis on the first hour. Then recording the baby's weight. The recommendation is it's preferable. First, keep the baby with with the mother, the mother put the baby on the breast and all that. You don't need to rush to take the weight. Vitamin K, we can't emphasize that enough. And it's one of those recommendations on our national guidelines. Every baby born should receive vitamin K. 1 milligram for the term baby, IM, and then 0.5 for those less or equals to 1.5 kilograms at birth. And these are mostly the preterm babies. So we need to ensure that, they receive this. One problem with vitamin K is that sometimes they're given, but they're not documented. So the documentation of these interventions are also very, very important. Okay. Cover the baby's head with some cloths. Okay. It doesn't have to be too much, but at least something. Okay. And then this is a baby who is crying and active and kicking and all this. Put the baby on the mother's tummy and cover them together. The mother's abdomen is not dirty. Okay. Then there is the aspect of resuscitation, which we're not going to dwell so much on. But at all delivery points, you need to assess this baby for a need for resuscitation. And this should take the shortest time possible because you do not want to lose the golden minute. If this baby needs to be helped to start breathing, the first ventilation is 1 minute. Anything beyond that, the outcome is not going to be as good as all of us would desire. Okay. So as the healthcare practitioner, imagine you are the parent. What would you want for yours? So every time you're about to do what you're not supposed to do or fail to do what you're supposed to do, just imagine that was yours. How would you want the things to be done? So because of this, we need to have this vigilance and we have to make the necessary preparations, even if it is an anticipated normal delivery. And make sure you have your resuscitation equipment in place. Okay. The other one, which is very difficult in our setting, is having at least one skilled person at resuscitation at each and every delivery. This is really wishful thinking as it is right now, but I think it's something that, we really, as a country, we need to work on. Maybe as a region, we need to work on, okay? The people who conduct these deliveries, do they actually know how to resuscitate? Does that midwife know what to do? Does that obstetrician know what to do? We are not blessed with enough pediatricians to attend every deliveries. In Kampala and so many other places, most deliveries in the private hospitals are attended by a pediatrician. The babies are received by a pediatrician. And the reason is because they know what to do when it comes to resuscitation. But in a setting where you do not have these people, the immediate people, the ones who are carrying out the deliveries, do they know what to do? So I think it's something that we need to work on for people who are doing this. If they're not trained, we need to have frequent trainings on newborn resuscitation. And the people who are supposed to lead it, to me, are supposed to be the people in the obstetrics department. Okay. Resuscitation flow. Briefly, I'll go through it. Every baby who is born, you need to know the time, like I mentioned earlier, receive the baby, dry the baby with a warm cloth, okay? Now, I said the drying, that whole process is stimulating the baby. If there are no issues, this baby is going to start crying, it's going to start breathing and all that. So you're going to ask yourself, is the baby crying or breathing? If the baby is crying and breathing and all that, you're going to do the routine care. Dry the baby, put on the mother's abdomen, provide warm skin to skin, cut the cord after some time. Don't cut it immediately, and carry out the ongoing evaluation of this newborn. But in the event that this baby is not crying, is not breathing, okay, this is a baby who needs to be resuscitated. I hope you all agree, okay? So for this baby, you're going to cut the cord immediately. You're not going to wait for 1 to 3 minutes. No, you're losing the golden minute, okay? Cut the cord immediately, put the baby in a warm place. If you have a radiant warmer and a radiant warmer, provide those initial steps till you dry, position, check the airway, if there's secretion, suction, as you try to stimulate. If after 30 seconds, the baby is probably gasping or is apneic, the heart rate is less than 100, this is a baby who needs what? You need to start bagging. But if you have done that and then the heart rate is greater than 100, is not gasping, is not apneic, okay? And maybe the breathing is labored and the cyanosis, this is a baby who you're not going to keep with the mother. But if it's not cyanosed, the baby is breathing well after you have done all those things, do the other routine care, give the baby to the mother, okay? Remember, the positive pressure ventilation or the ambu bagging in the common term should start at a peak of 60 seconds. Babies where this is started much later tend to have poorer outcomes. Sometimes they'll survive, but these are the babies you're going to have coming to you in the future with cerebral palsy. So they're going to miss that opportunity of becoming doctors and nurses like some of us. They're not going to become engineers, they're going to become pilots because their brains are messed because of what we failed to do at the right time. Now, should you start doing your positive pressure ventilation? They say the rule is first give 5, inflations of 5 breaths. The majority of them, after you've given the 5, they're going to start breathing, okay? Okay, they're going to start breathing, fine. But in the event that they are not, you're going to continue for probably another minute. And then you're going to do your evaluation, okay? If the heart rate drops to less than 60, then this is a patient who requires chest compression together with bagging. Now, one thing that I'll emphasize is for every baby who is, after you have done the other first things of drying and all that, is gasping, is having apnea, or the heart rate is less than 100 beats per minute. This is a baby who requires positive pressure ventilation. This is a baby who requires bagging, okay? If the heart rate drops to less than 60 beats per minute, this is a baby who requires chest compression together with bagging. Now, we have another unfortunate case scenario. You are alone. If you are alone, even if the heart rate drops to less than 60 beats per minute, all you're going to do is bag. You're not going to alternate chest compression and bagging when you're alone. This simply means when you are anticipating that maybe the bagging is going to take a little longer, call for help. The helper is going to help you in taking the vitals, but also if there is need for chest compression, that person is going to help you with that. And then after that, if things are not working, that's when the issues of the drugs will come in. Now, the drugs, I do not like to talk so much about it because I believe most of our babies do not actually require the drugs as long as you're able to provide the appropriate positive pressure ventilation. Unlike adults where you may need the drugs and the chest compressions come in handy, most of our babies actually have normal hearts. All someone needs to do is help them start breathing. And that's where the most important step in newborn resuscitation is the ambu bag. And all of us should get hands on and learn how to do this. Thank you. Now, where do these babies go from the delivery room? The majority of them ideally should be with their mothers. Okay. But then you have special, scenarios where these babies may have to be separated from their mothers. They have to be sent probably to the NICUs. Okay. Those who are less than 1.5 kilograms, less than 34 weeks of gestation, those with major congenital malformations, those with severe birth injuries, those with respiratory distress, those who have bagged for more than 1 minute, they need to be observed. You're not going to leave that one with the mother. Okay. It could be for 24 hours. If everything is okay, yeah, you give back to the mother. Those with congenital malformation that probably require immediate correction, you cannot leave them with the mothers. You have to try and do something. Okay. Even if they don't require immediate correction, sometimes they need to be observed for some time. Okay. And if they're deemed stable enough to be with their mothers, then you can give them to their mothers. Severe birth injuries, a lot of times we have birth asphyxia, but then there are physical injuries that a lot of these babies get. Okay, you have things like cephalehematomas, you have fractures, you have these ones who come with your first presentation and the whole face is swollen up and bruised. Okay, some of these babies you have to observe them over time. Interestingly, a lot of them they recover after a very short time. Okay, yes. So the take home is the majority of them, because they're born normal, they're going to be with their mothers. And then the others, there are few who will require some special care. Next thing is the immediate cord care. You need to clamp and cut the cord with sterile instrument. We talked about that earlier. Tie about 2 to 3 centimeters from the base, observe for oozing. There's no need to apply any substance to the stump. You do not bind or bandage this to the abdomen, for example. Okay. The recommendation, try as much as possible, leave it uncovered. That is cord care. Now, I know there have been so many things being tried, do we use saline to clean? Do we use chlorhexidine? All this, okay? But the best is to leave it alone and keep it dry, okay? Some of this is because you want the caretakers, once they go home, to feel they're doing something, because that's how we are. For everything, every condition, every illness, we want to try and do something. Okay. And because of that, you've had scenarios where so many things have been put on the cord stumps, ash, cow dung, soil, all these things. Unfortunately, things like neonatal tetanus still there. Most of them stem from poor cord care. Yes, on top of the mothers not receiving their tetanus shots during the pregnancies or during their adolescence. Yes. The warm chain. Remember, one of the things we said, these babies, irrespective of where they've been born, they require some bit of warmth. Okay. Now, we know that the newborn babies, especially the preterms, are very prone to getting hypothermic. So because we have that at the back of our minds always, one, we need to have a warm delivery room. You need to dry the babies immediately. You need to provide skin-to-skin contact. Put the baby on the mother's abdomen, okay? Start breastfeeding. Postpone bathing. Vernix is not bad. Vernix is that white thing that most babies are born with. Okay, that greasy white thing. Now, that thing is not there for just being there. It is very important. When the baby is there, because it's greasy, it protects these babies from the effects of the amniotic fluid. For those of you who have gone swimming, after you've been in water for some time, you come out or you are still there, your skin gets wrinkled and all these things. Okay. So this vernix really protects the babies from that, but it also has antimicrobial property. Okay. If you have seen post-term babies, a lot of them come with very dry and peeling skin. And it's because as they reach term, the amount of this vernix keeps reducing. So now post-term, sometimes it's gone completely. So you're going to get these babies who come the skin is very dry and wrinkled. They look like old people, right? Okay. Because the vernix is gone. Okay. So you need to postpone, but also immediately after birth, it helps with that initial regulation of the body temperatures, coming to adjusting to what the temperature is outside. Okay. The vernix is very important in that. Okay. So apart from protecting the skin and keeping it moist, it has antimicrobial properties. Okay, but it also helps them to adjust to the temperature outside of it, of the womb. Provide appropriate clothing for the babies. Appropriate clothing, not too light, not too much. So the recommendation most times is how the mother feels. Are you feeling hot? Are you feeling cold? No matter how you're feeling, twice what you're wearing is good enough for the baby. Okay, in our settings, we have all these very nice woolen things that we have adapted from the countries that have winter. So irrespective of whether it's December, January in Gulu, the baby is going to be covered with 3 layers of thick woolen things. So it's up to us, the healthcare practitioners, to guide these mothers on how they are supposed to address these babies appropriately, and then try as much as possible to keep the mother and the baby together, unless both of them are either of them is unwell, is critical and requires more advanced care. And then for those you are going to refer, you need to ensure that your transportation, the ambulance or whatever you're going to use, is warm enough. We've had stories of preterm babies being referred from lower level health facilities to higher level facilities, but then by the time they reach, they are gone because no one paid attention, that warm chain. Okay. So how do these babies lose heat? You have those, we all have some bit of physics background, I believe, and we know what all these things mean: convection, evaporation, and radiation, and conduction. Conduction, you put this baby on, for example, a metallic surface. They're going to it to take away the heat from the, okay? Radiation, if the walls of whatever the baby is, it will take. Convection, if you have these delivery room which has windows which are opened and like, no shutters and all that, this baby is going to get cold because of convection. And then evaporation, the babies come out wet. Hence the emphasis on drying them up. Okay, dry them up. Okay, to avoid like, heat loss from evaporation. These are the things that I've talked about from the other previous slide. Okay, evaporation, the baby is wet. Immediately after bath, like you're dry. After drying, put away that cloth that you have used for drying. Okay, conduction, put the baby on the mother's abdomen. Don't put the baby on like a metallic pan or a table that has a metallic surface. Keep the delivery room warm. Keep the room warm to avoid like a heat loss through radiation. Okay. Next up is kangaroo mother care. This is from so many studies, the most cost-effective way of providing warmth to the newborn babies, especially those with the low birth weight babies. On top of like, providing the warmth, there are other benefits like, bonding. The mother is bonding with the child, protecting from infection, like, promoting breastfeeding, physiological stability, all these things. So for all our facilities where we have a newborn, corner, we should at least try to provide a bed or two or some chairs for these mothers to do the kangaroo mother care. Now, it's erroneous that is called kangaroo mother care, but this can actually even be done by the fathers. Okay. Even the grandmothers can do this. Okay. So in the event that the mother is not capable of offering this, the next immediate person should be able to like, provide this, okay, for the baby. Now, this is something that you can start doing from the hospital, but even after they've gone home, they can continue doing this as long as like, you have recommended it, for them. In other facilities, they have like a log where like they're supposed to like, track like the durations of like, how long the mother has been doing this. Anything less than 1 hour is not good enough. Okay. Yeah. So kangaroo mother care is very, very important. Okay. Remember, hypothermia in the newborn babies, unlike us, is any temperature less than 36.5. Okay. A baby with a temperature of 36.4 is hypothermic. So you have to have that at the back of your mind always. Okay. Whereas for the older children and us, the adults, like they say less than 35.5. But for the newborn babies, less than 36.5, they have hypothermia. And you have to put some intervention in place. And we have said the cheapest is to do what? Skin to skin. Yes. Breastfeeding emphasis is within the first hour. It's up to you to make sure this mother, like, there's good positioning, attachment, and effective suckling. We all know that like that suckling stimulates what? The milk production. Yes, sometimes I can tell, oh, the baby is trying to suckle, but there's still no breast, like no milk coming. Tell them to continue. The milk will eventually start coming. Yeah. And as a healthcare practitioner, for you, you have to observe minimum of 4 minutes of sitting. Always struggle like, to position, like they don't know what a good attachment is and all that. So postnatally, what are the things that you're supposed to do in the postnatal ward? Now, this is an area that we also tend to do very badly. The recommendation is that when a baby is born, they should spend at least 24 hours. in the health facility before they are discharged. But I'll tell you that there are babies who are delivered at 4 a.m. and they are discharged at 8 or 9. That is one day to the people who are doing the discharge. But the recommendation is that they should spend at least 24 hours in the facility so that you observe and see. There are babies who are born okay, but they deteriorate. Okay. Hence the need for you to observe them for the first 24 hours within the facility. Do not rush to get rid of them. Now, there are certain key things that we shall have to do. Let's move on. Warmth, we can't emphasize that enough. Keeping the mother together, we cannot emphasize that enough. Okay? These are repetitions of the things that you already overemphasized. Let's move on. Examination. Another area that we do dismally. Count the respiratory rate for a minute. Look at the chest. Does the child have increased work of breathing? Is the child grunting? Is the child having chest indrawing? Note these things. Look at the umbilicus and the skin. Do they look normal? Or the base is all red? Or there is some bit of bleeding. Check the axillary temperature. We have said if it's less than 36.5, this baby is hypothermic. If this is a stable baby, get the mother to do skin to skin. If it's not a stable baby, look for other alternative sources of warmth for this baby. Be it an incubator, a radiant warmer, okay? Look, a normal infant is always once they are awake, they're always kicking and all that. They have most of them are inflection because of increased tone in limbs. But if you see this one who is all lethargic, there is a problem. Okay. Look for jaundice. Now, jaundice usually appears most of the time around the second, third day. Okay. So sometimes even if you keep them for the first 24 hours, you may not be able to see that. But we also know that jaundice appearing within the first day of life is pathological. And it's up to you as the healthcare practitioner to be able to look for this. First-time mothers do not know if the child is yellow. They do not know if the child is very lethargic and sleepy. She is happy because she thinks my child is just peaceful. But for you, this is supposed to be of concern. And because it's of concern to you, you have to also make it of concern to her. Okay? Look for malformations. So you need to thoroughly examine this baby from a head to toe. And you have to have somewhere where you're going to document these things. Breastfeeding, this one we talked about already, at least 4 minutes of seeing attachment and all these things. Let's move to the next. Normal phenomena. There are certain things which might be of concern to the parents, but you as a healthcare practitioner, you need to know what is normal and what is considered abnormal in the baby, so that you can tell them what they need to do if at all there is anything that they need to do. Okay, so milia, for example, you have seen babies who have things that look like pimples. They are whitish on their faces. Okay, those are those are normal things. Okay, they should not be worried about that. Okay, things like Epstein pulse. You have there are those systems that sometimes you see in the baby's mouth. It could be on the palate, it could be on the gum, it could be on the floor of the mouth and all that. These are normal things that are going to disappear. Okay, so you should be able to tell them this one here, you don't need to worry, just observe. There's nothing to be done about it. It will go. Okay, things like Mongolian spots. This is mostly seen in the people who have like the pigmented skins like us, okay? You'll find like there are babies who have like, spots which are a lot darker. Most of the time it's in like, the lower back areas towards like the butt. And this is related to really the migration of like the melanocytes from the neural crest and all that, okay? So it's thought that the migration is arrested somewhere. Now, this persists most of the time for about a year and they disappear completely. So these are things that, they should not get like, worried about, okay? Capillary nevus, what is thought of as like, abnormal, like, what we call like, vascular malformation, that, tend to disappear. Things like, enlarged breasts, the effects of the maternal hormones, okay? These are things that will like, they will go away. Don't tell them not to squeeze that breast, even if it's enlarged. A lot of times mothers get so concerned, especially if it's a male baby and the breasts are getting enlarged, like you get so worried, they start squeezing and all that. Tell them not to squeeze. Those are effects of like the maternal hormones. Those things are going to like resolve like, on their own. Transitional stools, the newborn babies, like from passing meconium, eventually they're going to start passing like, stools, which to the mother sometimes seem to be like a lot loose, okay? So for mothers who have had other children, they will say, my child is having what? Diarrhea. You need to tell them like, this baby is like, adjusting to all these things, okay? The stools are going to become okay. And besides, a child's stool most of the time is a little loose compared like, to that of an older person. Things like vaginal discharge and bleeding in the female babies, effects of the maternal hormones. Sometimes these hormones are passed through the placenta, okay? And all these things like, will disappear over time. So the white discharge, because like, of the effects of the maternal hormone, there is some hyperplasia of like the vaginal mucosa. The baby is born, that supply of the hormone is cut off, all this is going to break down and you're going to have a bit of discharges starting usually at about 4 days. Sometimes they get like some rashes, okay, biliaria, okay. That is, it's not worrisome. Every newborn loses some weight, okay, and most of this is related to like the heat loss and the water loss through those different mechanisms that we talked about, okay. It is normal. What is expected is that by the 10th to 14th day, at least they should have regained their birth weight. And then from there, the weight gain, if everything is okay, is going to be like exponential. Yes. Cord care, the cord, important port of entry for infections. So instruct them not to apply anything on the cord. Like I mentioned earlier, a lot of times you have things like, chlorhexidine, is it saline given to the mother? There's something called ambigel. But the dry cord care is actually the best, okay? After birth, you need to examine this cord stump after at least 2 to 4 hours. We've had scenarios where babies have bled to death because once the baby is delivered, you have tied the cord or you have clamped, then they are wrapped. The only thing you can see is the face. Much later, checking, there is nothing. Opening what was used for wrapping is all full, like soaked in blood. So you need to like, even if you feel like you have secured that cord very well, at least go back and check after about 2 to 4 hours, okay? The skin and eye, recommendation is bathing at least after 24 hours. But also the bathing should not be this one of like, getting the baby and immersing the baby in a basin. No. Okay. You can just like, get a piece of cloth and like, just wipe. Because one, you need to keep that cord stump dry until it drops off. Okay. Eye care, Routinely, you don't, but in our settings where you have like a STD is very common, it's mandatory to give them, for example, tetracycline eye ointment. And for those who will start showing signs of eye infection, even when you're giving them the tetracycline, most likely this is gonococcal, and you have to give them a shot of what? Ceftriaxone. Okay. So in our setting, eye care is not optional. Okay. Yeah. Counseling. First-time mothers especially are very, I don't know, they look at the babies as like, very fragile being, which is very understandable. Okay, it's very understandable, especially the smaller ones, the low birth weight ones. Okay. But it's up to you to counsel them so that like they are comfortable in handling this baby. Because we say the most important way to provide for them warmth is keeping them like on skin to skin. 2, frequent breastfeeding, and it should be exclusive breastfeeding, unless there are other, things beyond control that will probably make her not to be able to like, exclusively or breastfeed this baby at all. But the recommendation is exclusive breastfeeding from birth until 6 months. Let these mothers wash their hands before they handle the baby, after using the toilet, after cleaning the bottom of the baby, and all these things. Now we have one challenge, even for our patients who are in the hospital, the newborns who are in the hospital. Yes, in Africa, we know that the birth of a baby is like, it calls for celebration. Unfortunately, sometimes even the sick ones, like people would want to come and visit them and carry them and, in the hospital and all that. And most of the time, these are people who are not going to wash their hands. They're so excited, but then again, also they don't know the dangers that they're bringing. Okay, so they're overtaken by this excitement. And sometimes when you try to tell them also, sometimes they get a bit offended. Okay, but it's up to us to like, figure out how to like, guide them and tell them why it's important for them to like, put those things in place. Okay. And for those who are admitted, I'm sure when we talk about the care for the newborn, one of the things is restriction of visitations. Okay. Immunization. We know that for all our babies, they are supposed to receive the BCG vaccine and OPV0 shortly after birth. It's up to us to ensure that this happens, especially for the babies who are born in the hospitals. Do not let them slip through like the system without getting this. Then we have other considerations for the HIV-exposed babies, nevirapine prophylaxis. This means at the time this mother comes for delivery, you probably have to like, test her so that we don't have like this missed opportunity. I'll tell you that in these recent months, we are seeing an increasing number of young infants who are HIV positive. And these are babies who are delivered in the health facilities. Young as 3 months, 2 months. Okay. So these are the ones that you'd probably think the system failed them. Okay. Something did not happen. Something was not right. Okay. Hepatitis B post-exposure prophylaxis. I don't know of all of us who are listening to me right now who are in practice, how many of you actually know the hepatitis B status of these mothers who are delivering in your facilities? And for those who are positive, what are you doing for the babies? Okay. Because the recommendation is that every baby delivered to a mother who is hepatitis B positive should receive post-exposure prophylaxis. And this consists of the hepatitis B vaccine, the usual one, and then the hepatitis B immunoglobulin. Of course, being in Uganda, I don't know if you have facilities or places that have the immunoglobulins, but at least you have the hepatitis B vaccine. Now, the hepatitis B vaccine alone, which is supposed to be given at best within 12 hours of birth. If for one reason or another, the longest possible time is 24 hours. But ideally, it should be given within 12 hours of birth. So if you have both, you're supposed to give both of them. Okay. Now, the hepatitis B vaccine, which most of our facilities have alone, is able to protect this baby about 70 to 95%. If you put in the immunoglobulin, the protection goes up 85% upwards of close to 100%. But if you who is conducting delivery don't pay attention to this fact that this mother has hepatitis B, definitely you're going to do anything for this child. And for the children who are getting the mother to child transmission of this hepatitis B, we all know how infectious hepatitis B is. So I think it's something that we have got to embrace. Okay, don't only pay attention to HIV, but hepatitis B as well. Okay. The other thing is newborn screening. It's not being routinely done, especially for the the hemoglobinopathies, especially sickle cell, which is very, very, very prevalent in our setting here in this part of the country. But I think there are efforts nationally to have newborn screening, rolled out in all the different facilities. So every baby, irrespective of whether they tell you there's no family history of sickle cell, all of them to be screened. This helps in identifying those who have it so that you can institute the help that they need timely enough. And then the other one is the follow-up. Okay, so in summary, immediate or essential newborn care is that package of support, okay, practices that's will help in the survival and the well-being of the newborn. Most of our newborns are born normally, but if certain things are not put in place, okay, we lose them. And we'll say the majority of them first to the 7th day. I've not talked about the stillbirths. I've not talked about perinatal deaths and all that, okay? But we also know that that is another, area altogether. For the baby who has not started breathing, endeavor to start ventilation, endeavor to help this baby start breathing within the first minutes of life. Help the baby initiate breastfeeding within the first hour. Keep the baby and the mother together in as much as possible. Of course, barring those exceptions that we have highlighted, you need to identify and refer units who require special care. Now, I'll tell you, I work in Acholi Hospital, and one of the things that we've put in place to help us, yes, we are not referring them, but we are transferring. Sometimes they need to be transferred from whether it's theater, from the labor suite and all this to be taken care of by the pediatrics team. So one innovation that we came up with is to design a transfer form. This transfer form is supposed to be filled by whoever is transferring this baby, from whether it's the labor suite, from maternity, from theater, because it's going to capture a lot of information about what has been happening, from the time of birth. For example, what is the duration of labor? What was the time of delivery? What was the birth weight, the gestational age? Did the mother have any issues? What was the UPGAR score? What was done? Was the baby resuscitated? If yes, for how long? What exactly was done? So why is it that this baby needs to be transferred? So the reason, is it because the baby is having difficulties in breathing, the baby is hot, the baby is convulsing? And I think it's something that's we can all adopt, okay? Precautions to prevent infection. The universal precautions, okay? Hypothermia, skin to skin, counseling the mother on exclusive breastfeeding, and then help this mother to know what the danger signs are, especially the first-time mothers. What are those danger signs that she should look out for? The baby who is, very active, all of a sudden is excessively sleepy, is not feeding, you have to force her to sleep. The baby is vomiting everything. Maybe the baby is too hot, the baby is convulsing, the baby is crying inconsolably, the baby has become yellow, the baby is breathing too fast, and all these things. Help her to know these things, such that once she sees them, she knows that probably I need to go back to the health facility. Now, before I conclude, issues, I mentioned something about ABGA score, and I would want during the discussion that our obstetrics team help us. Recently, I tweeted about it, and I thought maybe we should find something else. Because we have scenarios where someone tells you the baby had an ABGA score of 9 at 1 minute, 10 at 5 minutes, 10 at 10. But then in the same setting, they'll tell you this baby was resuscitated maybe for 20 minutes. And you start asking yourself, the baby was scored 9 or 10 at 5 minutes. What business did you have to resuscitate this baby? So I'm actually doing this ABGA scoring, okay? And then also the other thing that probably should come up is there is the new concept. I don't know how new it is. The obstetricians will also guide on this. The extended ABGA score. Okay. So yes, you have a baby who was had an ABGA score of 3 at 5 minutes, and you have resuscitated. So you need to extend. Okay. So there's the post-resuscitation score. So you need to clearly but I think we probably need to go back to the basics and see what should we do about this, because at the end of the day, you're going to have statistics that reflect you have so many cases of birth asphyxia, but if you look at what they score, they don't they don't correlate at all. Okay. Otherwise, I want to say thank you very much for your attention, and I apologize again for the glitches. Back to the moderator.
Yes, thank you very much. I have enjoyed this session. It's been marvelous. I think members would love to join me and applause our guest speaker this afternoon, Dr. Venice Omona, taking us through immediate newborn care. I'm very happy for the information you gave us, and you realize that most of this information is guidelines speaking to us that we need to understand and implement in our daily practice. I thank you because we are in close practice with the pediatrician, as he has already mentioned. We work together at all times because we deal with this newborn all the time, the neonates, the newborn. Yes, Dr. Omona, thank you very much for the wonderful presentation. Members, of course, we have now this time for question and answers and clarification. But I know very well you have alluded into some few things. But yes, let us first allay the anxiety in some of the members who have asked questions. I think you can go to the part of questions and answers, and then we first answer them as other obstetricians would want to dive into these areas of ABGA score, and we see how we can make this session, the other part you have just mentioned. Now, I attempted to give some of the answers to the questions as members were asking during the process of your presentation, but I believe you want to a little bit highlight on critical areas as you give more of the aspect of the guidelines. But yes, members asked about hyperthermia in newborn. If they are there, what do we do? Of course, I thought this member was asking about hypothermia. However, I was asking about hyperthermia. Yes, it is important. Yes, you have been speaking a lot, our dear guest speaker. So that's why I will give you the opportunity to give your overview of these questions which are there on the part of question and answers. But yes, Alfred asked about how do we prevent hyperthermia in newborn, and then if hyperthermia is there, what is actually required to be done. But I think we need your input. But as I said, that hyperthermia is unlikely a problem, since most of these newborn babies requires one condition. So, but if it would happen that there's hyperthermia, then at one point, before you start thinking of features of infection and all that, we need to expose these babies for a few minutes while we are trying to examine these babies and then look for the cause of the hyperthermia. Yes, you'd dive in at immediately after me, and then you answer some of the questions and add on what I've just given as point of answers to make sure that the participants are contented. Yes, a member asked also that is there toxicity or side effects of administration of vitamin K if it is prescribed in a more dosage? I think you will also allude into this to give us more of the pharmacology aspect. But however, the noted evidence has been reported that the side effects involves rapid administration of the vitamin K. So we presume that even in larger doses, it will be there. And the commonest one is anaphylaxis. Others are there, which are very uncommon. So another member asked about if the Ministry of Health would think of retaining all midwives on newborn resuscitation countrywide. Yes, I would thank you once you back this with evidence in research studies. So I would really hope that Doreen will take it up and do a study, a well-controlled study that will help us change this policy. And in fact, it will be a very good thing for us to know is that the midwives, do they know resuscitation? How much are they doing about resuscitation? But is it in their docket to know how to do resuscitation, since we have other people who are like pediatrician? Ideally, they're supposed to be there to help us receive these newborn babies. And the policy does not change because of the comfort of one person. So I think a study would be good here. Then a member also asked about the commonest cause of hyperthermia, which we said, yes, and fever in newborn babies within 24 hours usually is dehydration, was giving us the input, and therefore breastfeeding is key, as they have been observing in other private facilities where they have been working. But still, I take this too, that if at all you think hyperthermia and fever in newborn within 24 hours is usually because of dehydration, then I think it would be realistic enough for us to do a study on this as well, to make sure that we have this thing documented, because nowadays, most of these evidence-based information are scientific, and so we need science to actually back up, and we change the protocol and the way we think, other than just a simple or one experience in one facility, then we think. But I'm not actually saying underestimating the importance of experience and expertise in what we do. Then almost coming to the last part of it is that how do we, okay, we have already talked about hyperthermia. And then somebody asked about Venice. Dr. Venice, your name is similar to Venice as well. So I relate this that this Venice is equally important as Venice, who is now our guest speaker. Yes, you are as important as the Venice we talked about. Yes, it is true. Vernix is, we can sometimes call it Vernix caseosa, is that white waxy coating that are on the skin of the newborn. In fact, you don't need to reduce this, since the importance is more than its lack or it's not being there. And normally in the first day, they tell you not to bathe this baby because you don't want to remove this vernix, which is a coating on the skin of the newborn. So it is actually important, as doctor has already given us the importance of this vernix. So vernix normally comes from during that period when the epidermal cells of the newborn is actually what? In the uterus is actually shedding off and mixed with the secretion that are there from the peridermal cells from the vernix. So I think that is briefly what I try to answer within that time when you are presenting our chief guest tonight. I think we still have more questions on the part of the questions that you can actually even go through. and give us your input. Basically, I would like you to also answer some of these parts, maybe for the benefit of time. I know we started late, so we want to compensate for that time as well. So what is the commonest, okay, the component of the golden hour or minute, as you mentioned, or what should be done during this golden minute? I think briefly we'll mention it. And then the other question is that, is it abnormal for a newborn to pass meconium in the form of fecal pellets had to like for a goat? Yes, you also answered it a bit here, but I think this is not abnormal, absolutely. And then hepatitis B vaccines alone is not routinely found or given in most government health facilities, but the common available vaccine is a combination. Hep and Hep B vaccine that is always given at 6 weeks from date of delivery. So can we go ahead to recommend this Hep plus Hep B vaccine combination? I think we just give a quick rebut on that. It is a skill issue with scoring babies because this cuts across in almost all facilities. So Vicky was asking, I think he's talking about the APGAR scores relating to what you have given. Therefore, of course, it is important now to just give a brief thing about APGAR score. It's something very big. Yes, APGAR scoring system actually was started by a man called APGAR, Virginia, in 1952, and when he started proposing this, what APGAR, so the APGAR is in some acronyms that is derived from that name of a human being. So this practice of APGAR scoring, A is talking about appearance, G is grimace, then we have P is pulse, and A is activity, and then R is respiratory rate. So APGAR. However, it depends on the person who is scoring and if the person knows how to score. So sometimes someone will give you a score which is not corresponding to the actual score that the baby actually scored when the baby was born. So I presume that this is about skill base, as someone has said. I think we need in our training, and that's why we have this kind of CME to help us. But for the school book today, we can't go deeper into the APGAR scoring system, which give a parameters, a maximum score of 10, and can be scored at 1 minute and then at 5 minutes. But you can have that extended score, like you said, when you need to do some resuscitation, like for example, bagging and mask, then you need to continue scoring this baby and see how this baby is going to improve on the resuscitation that you are giving. So you can still use this extended mode of scoring and still the using of APGAR. So I think some of the questions that I asked, I think our chief guest can respond to those few questions. And then if we still have more members who want to raise up their hands, we will choose you to ask questions in the group. Dr. Venice, you're most welcome. I'm sorry you have some issue with I think your right hand. I wish you quick recovery.
Thank you. Yeah, surely. Thank you very much, Jimmy. And then thank you to the participants who have raised some questions. Yes, one about, let me start with the issues of the hepatitis B vaccine. So the recommendation is that for the baby whose mother is hepatitis B positive, okay, you're supposed to give them the hepatitis B vaccine plus the immunoglobulin within 12 hours, latest 24 hours, okay? That is post-exposure prophylaxis. Now, this baby, once he or she gets to the other age, 6 weeks, 10, 14, they are supposed to get the other series as well, okay? I hope that is clear.
That's
so
clear.
What they are, yeah, that is what they are getting first is post-exposure prophylaxis because the mother is positive, okay? Does not exempt them from getting the other series that they are supposed to get at like the appropriate, stages or the ages, okay, as they move on, okay? Now, the issue of existing in combination, I believe most of us healthcare practitioners actually receive the hepatitis B vaccination. Yeah, at least I remember when I was in medical school undergraduate, will receive like the 3 shots. Okay, so the hepatitis B vaccine should be there like as a standalone vaccine, because we know that even as adults we're supposed to receive it. Okay, so that shouldn't be an excuse. The only thing that's being given together with the other vaccines at those different what? Okay, at those different age groups, so 6, 10, and 14 weeks. Okay, related to that, I see someone has sent what dose? It's usually 0.5 ml. Okay, 0.5 ml IM. Okay, vitamin K. There been very, very, very few reported cases of toxicities of vitamin K. But if it's given IV and it's given rapidly, there have been reported cases of arrhythmias, okay, in the babies. For your information, the vitamin K can also be given as an IV, okay? It's not totally, it's supposed to be given as IM, but can also be given as an IV. But when given IV and is given rapid, there have been reported cases of some bit of arrhythmias. But the other documented, what you would call side effects or adverse effects, which also might, require some bit of studies to find out if it's actually the main cause, things like, hyperbilirubinemia, jaundice, neonatal jaundice, okay? We already know that once a baby is born, they have an extremely high hematocrit. And because the extrauterine environment is rich in oxygen, they do not need this extra hemoglobin. So they're going to definitely hemolyze. They're going to develop some bit of jaundice. As long as it starts beyond the first day of life, most is physiological. They're just getting rid of the excess, okay? And this jaundice, if unless it's too much or unless this baby has other risk factors, it resolves, okay? So there have not been any life-threatening, issues with that, with the vitamin K. Hard meconium, it can happen, okay? My surgical colleagues will tell you there have been cases of newborns with features of intestinal obstruction. And you know what is causing it? What we call meconium plug. So much as there's meconium aspiration, there is also meconium plug syndrome that you can interest yourself and look at. Okay, sometimes they have very hard meconium, they get it blocks the intestines, and then they start getting this distension and all that. Okay, so yes, it can happen. Okay, that the meconium can be very hard sometimes. Golden minute versus golden hour. I don't know about golden hour. My focus is the golden minutes, 60 seconds. For the baby who is not breathing, okay, you have dried, you have stimulated, the baby is not breathing. 60 seconds, start bugging that baby, okay? Like I highlighted earlier, most of our babies have normal hearts. All they need is help them start breathing. Once you do that and you do it effectively, okay, they're going to be fine, okay? So it is 60 seconds, okay? That is the golden minute. Go and look at all the different newborn resuscitation protocols. Most common one is the helping babies breathe, okay? Which I think every labor suit should have actually that protocol on their wall. Every theater that does cesarean delivery should have that. Now, we have one problem with resuscitation that probably I should have highlighted much earlier. Standardization, okay? Babies who are delivered in theater most of the time are resuscitated by the anesthetic team, who tend not to follow this helping babies breathe resuscitation protocol. They do it their own way, okay? So a lot of times you have shortcuts. People are giving them adrenaline when they have not actually been bagging. They have not bagged, they have not done chest compressions and all this. But we said most of these babies have normal hearts. All you need is to help them start breathing. BCG, sepsis, no relationship, okay? You can give. There is no problem, okay? The other thing I want to emphasize about immunization is that in the past, and I'm very sure that this is still happening in a number of our facilities, preterm babies are not being vaccinated. They are waiting. The current recommendation is give them the vaccines as you would give a normal term baby, okay? So if you are in a place that has a NICU where you host these preterm babies, Get the people who do the immunization to come and immunize them from where they are. Okay. Let them receive the series the same way as a term baby would. Okay. There's no contraindication in that. With Vanix, we have talked about that, and it's very important. And a lot of time, it gets resolved. Okay. It gets resolved. One thing is, it's not dirty. Do not rush to wash it off. Okay. Hypothermia. Yes, much as hypothermia is a problem, hypothermia can also be a problem. Now, most of these babies that we, in most of our facilities, treat for neonatal sepsis are actually babies who are actually having what? Neonatal hypothermia. Okay. Most common reasons why they are hot, they're dehydrated, you have covered them too much. Most times, when you expose them, the temperature magically just comes down to what is normal. Okay. But in the event that you have exposed and the temperature is not coming down, then this is a baby who probably has other issues. There might be like, this is a baby who might be septic. If they do not respond to like the exposures, sometimes you can be like, you can even give them like, some IV fluids. Okay. If they're like, you think they are dehydrated, 10 mils per kilogram body weight of normal saline, expose them. A lot of times the temperature is going to come down. Okay. I'll give you another scenario where we have a lot of babies who are admitted with supposed sepsis. You admit them today because they are very hot and all that. The next day you want to review them, they are not there. The temperatures come down, the mothers think their children are not sick. Why should I stay? Okay. They leave without telling you because the baby is fine. Okay. So for all of us who are in practice, especially those are in who deal with the newborns, the best marker of sepsis is actually hypothermia. This baby who comes with a low temperature is likely to be toxic, is likely to be septic compared to the one who comes with a high temperature. So do not rush to like, for this one who is hot, like antibiotics and all this. A lot of times they're either like they've been covered with too much, which we do a lot, or they are just dehydrated because they have not been breastfeeding for one reason or another. Okay. Yeah. I think those are the queries that were raised, unless there are others.
Yes. Thank you. Thank you, Venice, for the wonderful answers you've given.
Yes, I see there's one thing here. Doses of what immunization, the preterm, give them the same dose. Okay, give them the same dose. Okay.
Yes. Yeah. Thank you, Dr. Venice.
Yeah.
Yes, I think some people wish to ask questions. Let me allow them first to ask some few questions. I'm giving the 3 people who have been raising up their hands. Let me start with Dr. Pebalo Francis. Please, may you ask your question or your concern? Dr. Pebalo Francis, please. Unmute and then ask. Dr. Pebalo is not there.
Yes, I'm here.
Yes.
Thank you so much, Venice. And I think this was one of a very good presentation that would help our babies now to live. And as obstetrician, we have actually learned a lot, and we keep learning as is required. I want to ask 2 questions. One is on permissive hypothermia. I think some people have been thinking, probably some researchers have been done, that permissive hypothermia can be used for treating cases of probably birth asphyxia or poor score. I don't know what your take is on that. And the second question relates to routines.
Yes, go ahead, Dr. Pebalo.
The midwives normally do suctioning for every baby, and even if the baby does not have any mucus plug or something that they need to suction, you see a midwife is really suctioning. So I don't know what your take is on that. What is the evidence of routine suctioning versus suctioning when there's really needs for suctioning. Thank you.
Yes.
Okay, thank you very much, my senior. Let me start with the last one about suctioning. The recommendation is if the baby is born, the baby is crying, is breathing well, you don't need to suction. Even the ones who are born through meconium stain amniotic fluid, as long as the guy or the girl is crying and is kicking and doing all these things, you don't suction. But if the baby is not breathing, has not cried, you're supposed to check the mouth. If there are no secretions, and this was also, and also the amniotic fluid was not meconium stain, you probably don't need to suction. Maybe it's the tongue that is blocking, or it's something else you need to position, okay? So routine suctioning is discouraged. You're not supposed to suction every baby. Only those ones who are probably meconium stain amniotic fluid and is not breathing, is not crying, or you see obvious secretions in the mouth. Those are the ones you're supposed to suction. And then the other thing is that the suctioning is suction only up to where you can see. So you're not supposed to use a suction tip. No. We have the bulb syringes and the penguin syringes. Suction only up to where you can see. Okay. If the baby is born through meconium stain amniotic fluid, the baby is not breathing, is not crying, that is the baby you're supposed to suction. So you're not supposed to do it for everyone. I'll tell you in practice also, I've had infants, these are not newborns, infants, okay, who come with issues with breathing. A lot of them have upper airway malformations, laryngomalacia and the rest. There's striders and all that. Most of the time, you know what the story is the mother the mothers will tell you. For those who speak low, or for you, my baby was not suctioned. Okay. And it's an information that us, the healthcare workers, are the ones who are giving to them. Okay. Because in our minds, we believe every baby born should be suctioned, but that is not a baby who is active and crying and doing all these things does not need. What are you suctioning? Anyways, I know sometimes you want to satisfy your psychology, but it's not okay. The girl or the guy is active and crying and doing all these things. They don't, okay. And that is what takes me also to back to the other issue of the asphyxia that I was talking about. Someone has scored 8, just scored 10 at 5 minutes. Okay. And yet we know the definition of birth asphyxia is this one who has failed to initiate and sustain breathing at birth. And if you are to use the Apgar score, you're using the one at 5 minutes. Okay. So it is 8, it is 9. What were you doing? What are you why are you disturbing this newborn? Okay. So we need to let's put some thoughts into these things before we do them. Let's not be robots. Okay. I think we're all blessed with the power of reasoning. Okay. So we know if the baby actually requires resuscitation for 20 minutes, then this baby couldn't have scored 9 at 5 minutes for real. Okay. Yeah. The permissive hypothermia, also called therapeutic hypothermia. Yes, it has been shown to help in the management of babies with asphyxia. But, and this is the but that all of us should pay attention to, this can only work in a very well-controlled environment. Okay. There are two modalities. Okay. There's whole body cooling, and then also you have only selective head cooling. Okay. It has to be done in a very well-controlled environment. 1. 2, it has to be initiated within the first 6 hours. Okay. 3, because it's in a very well-controlled environment, there are certain monitoring processes that must be in place. Okay. I'll tell you, in Uganda, they tried to do a study on that in Mulago, but they had to stop it because the outcome was not very good. And probably because the environment was not as well controlled. Okay. as it should be. So yes, it is used, is one of those modalities that has been proven like to help manage like babies with asphyxia. But in our settings here right now, we talk about it. It's good to have this knowledge at the back of our minds, okay? But to implement it right now, I'm sorry to say that we cannot do that. But yes, it is one of those modalities, yes. Yeah, thank you.
Yes, thank you, Doctor, for wonderful, elaborate answers you've given. We have 2 more people, but we want them to be as brief as possible. Realized,
yeah, sure.
So we're just compensating on the time we lost. So let me have a question from Kahunda. Kahunda Kenneth. Kenneth, please, may you ask your question? Is Kenneth there?
I think that was accidental.
Okay, fine. Let us have Wilberforce to give a comment or questions.
Thank you very much, Dr. Opee Jimmyy, for moderating, and thank you very much, Dr. Omona. My name is Dr. Kabwel Wilberforce, and I work in Mulago in the Department of Thoracic. And I was actually impressed with this topic because we operate not only children, not only adults with lung problems, but also babies. So before we operate them, we also need to get them when they are fine. So some of my comments will start from a simple talk. That actually, if IPC is maintained throughout the whole process, before we receive the baby, after receiving the baby, then the outcome is good. What do I mean? Sterility. In case you're planning to deliver a baby, you either SVD or C-section, it is good to have everything sterile. And after delivering this baby, you're going to cut the umbilical cord. You should have surgical blades or a surgical sterile scissor. Or sometimes in crisis, you may use the ends of the surgical gloves, those rolled ends in a crisis. And then obviously, if you have the cord clamps is the best. But if that is at birth, but in case they bring to you a baby who's less than 28 days, it is always to assess the baby from head to toe. And it is very simple. You look at the fontanelles, if they are tense, we are taught by that time that you start suspecting. The child has a temperature, the anterior fontanelle is tense, then you start suspecting a meningitis, and you know what to do next. Or if it is very depressed, the child is also has a scaly skin and whatsoever, then you just know that probably this child may be having a temperature because it's dehydrated. And then you look at the umbilical stump, because so many times they bring babies when they are leaking pus from the umbilical stump, and that is what is causing the sepsis. And they bring to you the child is very septic and very sick. And really, you look at yourself and you really don't know what to do. But for us who are taught those days, we assess everything and we know where to start. Now, also, it is good to actually see to note the baby's weight and ask if you're not there, if the baby has any documentation. But if you are delivering a baby, please take the baby's weight, note the time and date, and actually label those things on any piece of good paper, because this child has a lot to do with the date which was born, and then label the baby's wrist or foot with the mother's names, and even the sex, because sometimes people have labeled baby's male. Then when you're checking, the child actually is a hermaphrodite. They have not checked for birth defects. And at the end of the day, we get a lot of issues. And why I'm talking about this is also that I'm pursuing another master's in bioethics, and we get a lot of litigation. And this one doesn't go the obstetrician alone, but it goes to whoever got in touch with this child. And the mothers actually remember, they say, oh, but my doctor was so and so, and actually checked the child. So let us document facts and facts will always be there even when you are no longer there. Now, the other thing also is also good to admit medical errors, especially if children are injured during birth, so that we note and we know what to do next. And even when you don't know, you feel free to talk to to actually disclose it to the mother, and then even give an alternative what to do. If it's a colleague, give a colleague a call. Even when you're in Gulu, give a colleague in Kampala a call, and you say this has happened, what do I do? Can I send? And make sure you arrange for the leaving of the baby and then transit up to the destination. And then also we should learn to communicate. I'm not saying everybody, but those ones who are not communicating, we learn to communicate to parents, because behind this small baby you're seeing is a barracks of people, including me. Apart from professionals, but the whole clan, everybody, everywhere, the whole world listening to a child, because that's our future. And then the customer care. It is very important to communicate what you know to the parents. What you don't know, agree you don't know, because learning is a continuous process. And then I talked about consultation. Colleagues, let us learn to consult in due time so that we reduce on morbidity and mortality. And then continuous reading is the key. Through these CPDs and CMEs, we continue attending so many, we shall learn a lot. Now, the other moment I wanted to talk about are the 5 moments of hand hygiene. Before touching a baby, after touching a baby, or getting into contact with the baby's fluids, or when you're planning to do a procedure or after a procedure on a baby, or the baby's surroundings. You should make sure your eyepieces are very okay. And then eminently vaccination. Sometimes mothers leave the hospital when they don't know their children are meant to be vaccinated. BCG and OPV in the first 2 weeks and latest, but if at birth, they should be given. And then obviously the hypo, I call them the hypos and the hypers. Sometimes we get children who have hypothermia. It's because the baby has been overcovered with a lot of things and the weather is too hot. And it is just a matter of reducing on the coverings and then the temperature. Why we fear the hypos and the hypers, both of them actually are not good because they don't come alone as they are. They are usually in a cascade of things. Because, for instance, if you're covering the child, they sweat themselves, they become dehydrated, and then at the end, we end up with even hypo, everything, hypo, even electrolytes also go down there, and we don't know. And we know that our diagnostics are still not very good, including up country and even urban places. So what I will emphasize is that let us continue doing the IPPA inspection. If where there's need, inspect the baby from the head up to the toes. Seriously, keep looking for abnormalities, and they will be very obvious, apart from those trivial ones that you can't see at birth. And then percuss if there is a need, but rarely we don't percuss babies. Or palpate them, please feel free to touch them. They look fragile, but they are very, very, very good to examine. I know most people fear newborns, but they are the best people to examine, especially if you know in which positions to put them and examine. Auscultate when there is need, especially if there are thoracic challenges or abdominal problems. Thank you very much. I'm always attending this Acholi Branch presentations. There's a lot to learn, and I'm a student, I'm a senior student because I keep learning. May God bless you all.
Yes, thank you very much. We thank God for all these opportunities He's giving to all of us, and we call it the Uganda Medical Association Acholi Branch, but we are attending this CPD series all over the country. So people who have subscribed, people who always get the link, they're always here to learn, just like all of us are learning. Thank you very much, everyone who has been with us the whole time. But let me ask Dr. Pebalo Francis to give us a closing remark. As Chair CPD Acholi Branch, you have already been told by Wilberforce that your work is doing great change in our community. Dr. Pebalo Francis, please.
Moderator, may I just say a few things before you invite the closure?
Yes.
One, thank you very much, Dr. Wilberforce. Like, you really summarize, like, almost everything that, we highlighted during the presentation. And I think we cannot emphasize those things enough. One thing is that the immediate or the basic newborn care, these are basic things. A lot of them, if you are to look at all these things that you have talked about, how much money do they cost? Almost nothing, okay? A lot of them is really about like the practice, like, okay? These are things that you can do without like, necessarily like, looking for, money and all these things. Now, issues of sepsis. I'm just like, begging my colleagues who are here, especially the ones who take care of these newborn babies, neonates. Before you baptize this baby as having neonatal sepsis, always try to find out what risk factors for sepsis this baby had. Otherwise, you're giving this baby these antibiotics for no reasons. They don't need it. So like, you're wasting their time. They're spending resources being in the hospital, paying for some of these things. If there are no risk factors, you can observe without any treatment. Always, always, always look for the risk factors. I know a lot of times we always tend to hide behind that diagnosis of sepsis and bacteremia. If there are no clear risk factors, watch, observe, watch and wait, okay? The other thing he mentioned was about hermaphrodites. Yes, for us in pediatrics, we tend to be politically correct and talk of disorders of sexual development or atypical sexual, development. Yes, a lot of times we get these babies much later, okay? This baby at birth is called Okelo because they thought it was a boy. He reaches a certain age, they are seeing things are not looking like Okelo. Everyone is lost, okay? They don't know where to like, okay? So you need to really examine the genitalia of these babies. And if it is not conclusive and you do not have the information, like my colleague said, refer to someone who can like, talk to these parents, okay? And to my surgical colleagues, do not rush to like go do surgeries on these children. There are certain investigations that must be done. Otherwise, you're going to like, do a reconstructive surgery, create like, a female genitalia, and then this person is going to reach puberty, will start growing beards, the voice is going to become as deep as mine. You know how traumatic that is going to be, okay? Or you're going to like, do a surgery, like, this is a male, like, okay? And then like it reaches puberty, the breasts are going to start growing, okay? So like, do not rush to like, do surgeries, like, on these babies. Otherwise, I appreciate everyone. There are some questions which were not answered. I think like for those who have my contact, you can send it like to my, can send directly to me. I'll be glad to respond. Thank you very much, moderator. Thank you very much, everyone, for the attention.
Thank you, Dr. Omona. We thank you, we clap for you, and we think next time you'll be invited again to make a presentation. Let me now allow Dr. Febala Francis to give a vote of thanks and we close this session.
Yeah, thank you so much, moderator, Dr. Jimmyy. Your name is now Opee. I think that's a new name. It's a good one. Thank you so much, Venice, for this very informative presentation. I think this is something that has been missing, and we believe that with this kind of presentation, a lot of lives of babies, newborn babies, would be saved. I think I remember what you guided the day we met, and then I think the day has come to pass, and I'm very happy that you delivered very important information, and not only to the members in Gulu here in Acholi sub-region, but to every members who are able to get this information. I want to apologize for the the technical problems that occurred earlier on related to opening the link later. So I believe that Dr. Opee has already gotten the contact of the Global Seed Coordinator, Seed Global Coordinator, and I believe the subsequent CMEs. It should be easy for us to get the links and also open the links early for members to attend. Of course, I am not sure how many members have attended, but I want to appreciate the time they've taken. Much as we took a bit late, we were able to wait. And that shows that this is a very important topic. And also on this note, Dr. Omona, I think it's important that you need to have another session that we already agreed on how you can handle the sick newborn. Because now this is the normal one that's born, but how do we handle the sick newborn? I believe there are many newborns actually out there that probably we do not handle them well, and probably we need to also learn how to handle them well so that we save more life. I want to take this opportunity to thank you so much. I want to take this opportunity as well to thank Dr. Opee Jimmyy for moderating this very successfully, and also the chair for UMA Acholi, and then the Acholi UMA fraternity. Thank you so much. Have a good evening.
Thank you. Have a good evening, everybody. We had a maximum of 71 people who attended this CME session, and this has actually been great. I presume that if we had started on time as scheduled, we would have had more than 100 people. So this is a great opportunity for us. People have persevered. We thank you. Keep there, always attend, and we learn together and we correct one another. And this is how we can move forward as a region, as a country, and as the whole medical fraternity. Thank you very much. You can leave at will, but I'm going to let this session end. For the issue of PowerPoints, Dr. Tebabo Francis is in charge of that as the chair of CPD. You can actually get to him, and then he will be able to give you what you require. As for now, for me and the guest speaker, thank you, all of you. I wish you a very lovely weekend. All the best. Thank you.
Thank you too.